Good morning. My name is Patty Mouton. I'm with Alzheimer's Orange County and the Hoag Palliative Care Advanced Care Planning Program. And we welcome you to this webinar broadcast talking about increasing and enhancing access to palliative care and the importance of advanced care planning as called out in our Master Plan for Aging for California. We'll start our webinar in just one moment. We're so glad you could join us this morning. Thank you for being here. We have people joining us. Even as we speak, more and more people are coming onto the broadcast. So we'll give everyone about another minute before we actually begin our formal program. Give everybody a moment to get online. Thank you. And good morning. It's April 22nd, and this morning we'll be discussing the California Master Plan on Aging, and specifically two initiatives that are called out in the California Plan. Numbers 49 and 50 that talk about enhancing access to palliative care and encouraging people to complete advanced healthcare directives and, where appropriate, the POLST document. Thank you for joining us. We're so glad you're here. A little bit of housekeeping. We will save questions until the end, but you can type in your questions in the chat box and we will do our best to get all your questions answered. And any questions that we don't address during the live broadcast, I will pose to our speakers and we'll send you out responses. We're here today because April 16th is the observance of National Healthcare Decisions Day. And so as part of that observation, we want to really increase awareness and raise and optimize visibility about the importance of advanced healthcare directives, appropriate use of the POLST document, and wherever possible to enhance access to excellent end-of-life care, palliative care, and hospice care. We have some excellent speakers today, and you can see from our schedule, we're going to zip right along. So if you would move to the next slide, please. I'm very, very excited about the collaboration that brings this program to you this morning between Alzheimer's Orange County, the Aging and Disability Resource Connection, the Orange County Aging Services Collaborative, Hoag, CalOptima, and the Orange County Advanced Care Planning Partners. Together, we're bringing you some really excellent experts in our local Orange County community to help us not only begin to understand the California Master Plan for Aging, but to really focus on why advanced directives are so important and why we need to enhance access to excellent palliative care. As with any of these important programs, we couldn't do it without the support of our special sponsors. So I want to call out Care Choices Hospice and O'Connor Mortuary for being really foundational supporters of this education for our entire Orange County community. Thank you very much. The recently released California Master Plan for Aging has 5 major bold goals. And we're going to be talking about those today from one of the experts in aging services in Orange County. But we're specifically interested today in initiatives 49 and 50 that relate to palliative care, advanced care planning, and use of the POLST document. Our speakers today are three wonderful, really expert local visionaries in aging services. We're very pleased to have Erica Danczak, who is the Director of Aging and Veteran Services for the County of Orange in Orange County Community Services, and her responsibilities include the Orange County Office on Aging. We have Dr. Vincent Nguyen, who is the Director of the Hoag Palliative Care Program, a board-certified geriatrician and palliative care physician, and really a local mainstay in growing the awareness and use of palliative and hospice care. And he has been, since 2009, the chair of our local POLST coalition, the Orange County Advanced Care Planning Partners. And joining us from CalOptima is Jackie Mark, who is a senior policy advisor for government affairs. And Jackie's going to be talking about how CalOptima is responding, because in the master plan for aging, specifically called out are those health plans that handle Medi-Cal beneficiaries. I'll be your moderator. My name is Patty Mouton. I serve as Vice President for Alzheimer's Orange County, and I'm also the Program Director for Advanced Care Planning for Hoag Palliative Care. Thank you very much for being here today, and I'd like to invite Erica Danczak to get us started. Good morning, Erica.
Thank you so much, Patty. Good morning, everyone. Thank you so much for inviting me to participate in this important event. And I'm excited to share a little bit about California's Master Plan for Aging, as well as the Orange County response to aging services during this period of COVID-19, and how that really has impacted and changed the way we interpret the Master Plan for Aging and some of the plans that we have for implementing in Orange County. So you'll see on the slide, our agenda for my presentation is for me to set the stage a little bit and talk about some of the demographics in Orange County in terms of our aging population. And then we'll move into an overview of California's Master Plan for Aging by just touching on the 5 bold goals that Patty mentioned. And then we'll move into some of the COVID impacts to aging services delivery and some of the lessons that we've learned and how we're going to parlay that into our Orange County plan for implementation of California's Master Plan. Next slide, please. So just to frame us a little bit, a message from Governor Gavin Newsom that's taken right out of the master plan, and that is that 10 years from now, California will be home to 10.8 million people aged 60 and over, nearly twice as many as in 2010. 1 out of every 4 people will be older adults, creating a seismic demographic shift in every aspect of our lives. So you'll see here the graph that we can see the growth rate of the older adult population in Orange County, and we're talking about those that are 60 and older. We've seen a steady increase in the Orange County older adult population over the last 10 years. Back in 2010, we had just under 500,000, and in 2019, we had just under 700,000 according to the US Census. And if you look at that orange line on that graph there, you'll see the projected change in the age group for Orange County between 2018 and 2040 is about 40%. Next slide. And just to break down some of the demographic landscape of Orange County cities, you'll see that same data broken down by city. On the left side, you have cities that have the highest number of older adults. We have Anaheim, Fullerton, Garden Grove as the top 3. And then on the right side is the highest percentage of older adults per capita, and those cities that have those highest percentages. So Laguna Woods, of course, with the Laguna Woods Village, Leisure World and Seal Beach puts them in a high percentage category, and then followed by Villa Park for the top 3. And then this is just a map display of that same data, and it really helps us for planning purposes in Orange County to know not only the volume of older adults in terms of growth rate, but where are the concentrations of those communities, so that when we start to talk about regionalizing services, we can make sure that we're planning for communities where older adults are concentrated. When we look at Orange County's older adults and their income, we have 35.3% that are making less than $15,000 a year, and we have just 9.12% that are making over $100,000 in annual income every year. The economic status of older adults in Orange County, we have 67% of seniors that are not in the labor force, but that means that we have 33% that are still working. We have 85% that are at or above the poverty level, but we also have 14.7% that are below that federal poverty level. We know in Orange County, because of the high cost of living, even seniors that are living on a fixed income, Social Security, it's challenging to even find an affordable one-bedroom apartment. So the economic status, the income level, plus the rate in population growth means that affordable housing is definitely one of our top needs and top concerns, and it is called out in the master plan, which I'll touch on in just a moment. So moving on to what is in the master plan. It does contain 5 bold goals, and then underneath those goals are 23 different strategies. And then underneath that, we have 132 action-oriented initiatives. And although the master plan is considered a 10-year plan, so this is a long game, those 132 action-oriented initiatives are things that we are expected to address within the next 2 years. So definitely have short-term initiatives versus long-term goals that we'll be addressing simultaneously. The master plan also, when it was released, was accompanied by a local playbook, and that is a step-by-step, real detailed game plan of how counties can interpret the implementation of the master plan for aging goals. The playbook includes some direction on taking a look at local data, as well as engaging our local stakeholders, and that really is an encouragement to partner that public-private partnership, because we know in Orange County, our stakeholders in the Aging Network are not just county government, but they are our community partners, our contracted service providers, community-based organizations, faith-based organizations, healthcare system. It really is a multidisciplinary approach in Orange County. The master plan for aging at the state level also includes a data dashboard, and that will show us how we're doing. And that data dashboard, I believe, was developed in partnership with the California Department of Public Health. And so that will be a way that we can really track those 132 initiatives to see how are we progressing toward our goals. And it's my understanding that that data dashboard will be able to be drilled down to the local level. So not only will we be able to see how California is doing, but we'll be able to see how Orange County is doing in those initiatives. But the master plan on aging is really meant to be a living document. It will be used to guide legislation. It will be used to advocate for funding for aging programs, and it will really drive policy change. Next slide, please. Okay, so looking at the bold goals, goal number 1 is housing for all ages and stages. And this is particularly important to us in Orange County because of what I just mentioned in terms of our growth rate in the aging population, the high cost of living in a large county like California, or like Orange County in California, and also the economic status of seniors on a fixed income and their ability to afford even just low-cost housing. So the overarching theme of this particular goal is that we will live where we choose as we age in communities that are age, disability, and dementia friendly and climate and disaster ready. The target for that goal is that millions of new housing options will be available to age well. And the strategies underneath that will be housing options, transportation, outdoor spaces, and emergency preparedness. Okay, moving on to goal number 2, which is health reimagined. Very broad brush. We will have access to care and services we need to optimize our health and quality of life and to continue to live where we choose. The target, how we know we will have reached that goal, is that we will have closed the equity gap and increased life expectancy. The strategies underneath this particular goal are bridging healthcare with the home, geriatric healthcare, dementia care, and nursing home innovation. Okay, goal number 3, inclusion, equity, not isolation. We will have lifelong opportunities for work, volunteering, community involvement, leadership, protection from isolation, discrimination, abuse, and neglect. And the target for that particular goal is to keep increasing life satisfaction as we age. The strategies that support this goal are inclusion and equity, work, volunteer, closing the digital divide, elder abuse prevention, strengthening state and local aging leadership. Okay, moving on to goal number 4 is caregiving that works. We will be prepared for and supported through the rewards and challenges of caring for aging and disabled loved ones. Our target for this and how will we know that we've reached that goal is that 1 million high quality direct care jobs will have been created. The strategies that support this are the caregiver support, good caregiving jobs, and virtual care expansion. And the last bold goal number 5, is affording aging. We will have economic security for as long as we live. The target of how we know we will have reached that goal is that we will have closed equity gaps and increased elder economic security. The strategies that support this particular goal are ending homelessness for older adults, income security as we age, protection from poverty and hunger. So looking at those 5 bold goals, at the same time that the state was working on the master plan for aging, we were blindsided by a global pandemic. And those of us that work in aging services at the local level really thought that maybe this would put a pause on the state's master plan for aging timeline. And in fact, it was quite the opposite. Because of the COVID-19 pandemic and its impact to older adults, it almost acted as though it was an accelerant. That's what we heard from Dr. Galley at the state level, that it really brought senior issues into focus. There are so many aspects in our society where seniors have been last, and COVID-19 has brought into focus why seniors need to be first. They've always been first at the Office on Aging and for those that work in the aging services field. But I think that the pandemic really raised community awareness of how important it is to take care of our seniors and to support them. So just reflecting on the last 13, 14 months, older adults were the first group to be impacted by the governor's stay-at-home orders. That fateful day in March when all of the senior centers were closing down, and we had to quickly come up with a plan B of how we were going to maintain just the nutrition services that are delivered through the senior centers. Since March of 2020, Orange County has seen about a 40% increase in services for basic needs, and that includes food. Our home delivered meals, congregate meal programs that were occurring at all the senior centers needed to be converted into grab and go meals so that they could be safely picked up and take home the food that they needed for the week. Personal care items, financial assistance. Our Office on Aging call center has seen a dramatic increase in our call volume for seniors reaching out for the first time during the pandemic. They didn't even know that about the Office on Aging or what services were available, but it was really COVID-19 that helped them to find us. And so we could really assess their needs and be able to respond appropriately. Like I mentioned, the pandemic has served as an accelerant for the importance of investing in our aging programs, and it kept the master plan for aging implementation on track. We know that for the aging population, that COVID is going to have a long tail, that seniors who have been at home for over a year, even with the vaccine, there's going to be hesitation to re-enter back into our community and to participate in some of the activities that the senior centers are going to be offering. Definitely concerns about isolation, both at the state and local level. Senior isolation has been a constant topic of conversation because with seniors being instructed to stay at home, many of them live alone, and we have seen the decline. Even the senior centers who are serving the seniors that are coming to pick up their grab and go meals, maybe even just once or twice a week, they've witnessed the decline. We've seen the research that COVID-19 pandemic has probably had a negative impact on life expectancy for the general population, but even more so for the aging population. We can see the physical, the mental decline, the acute frailness that maybe wasn't there pre-pandemic. So these are some lasting impacts that we definitely want to make sure that we pay attention to. Also, the digital divide. Never before have we relied so much on technology. Events and community education, much like the one that we're presenting today, are happening virtually. And we take it for granted because we're very used to using technology to get through our day-to-day needs. But seniors that don't have access to devices, those low-income seniors, that 14.7% that I mentioned earlier, that are living in poverty, that don't have access to reliable and affordable broadband internet. Also lack of education of even how to use the devices. So we can provide them with the equipment and we can provide them with the access, but we need to make sure that they are proficient to be able to use the technology in a way that helps them stay connected to families and friends, also to interact with their medical doctors, nurses, people that are part of their care team, a lot of telehealth appointments. So huge reliance on technology, and so we want to make sure that we support any investment that the state puts into technology, whether that's a tablet loaner program or making sure that we support legislation that provides affordable internet to low-income individuals, including seniors and people with disabilities. Next slide, please. So our response is that aging is changing, and it's changing the way that we deliver services. There have been so many creative solutions to maintaining services for the aging population because of COVID. And we want to make sure that we don't lose those, that this wasn't just something that we do temporarily because we had to, but that we really take a look at this past year as a year of reflection and to see what we can really commit to long term, that it just wasn't a good idea for the time, but it's a good idea for all time, and we want to hang on to it. We are really looking at the master plan on aging as a roadmap for how to improve the overall quality of life for the aging population. Our older adults have been deeply impacted by the pandemic, and I think the bright light in all of that is that it has really raised awareness of how important it is to address senior issues in our community and to make sure that we have enough funding and support to meet the growth rate, but also the level of acuity, because we're going to be seeing the senior population and the impact this pandemic has had on their physical health and their mental health. Post-COVID activities, we know we'll have to address senior isolation, and then we know that we're going to have to put some investments into technology to be able to help our seniors stay engaged. There are innovative and creative solutions that have resulted from COVID that we definitely want to hang on to. And the Office on Aging is not privy to all of the creative solutions that our community partners have been made aware of. So we definitely want to learn about that and hear about that so that we can incorporate that into our overall county-wide approach for Master Plan for Aging implementation. So our approach in Orange County, the Master Plan for Aging, as many of you know, was released by the state in January. I believe it was January 6th. And like I mentioned, this is a long game. We know that this is at least a 10-year plan with some short-term initiatives. And so I have to remind myself that we're still only in April. We're still only 3 months into the release of this master plan. And even though I can definitely appreciate that the state kept this on track and kept it as a priority, I also have to take a step back and realize that it was released at the same time that the vaccine was coming. And so that has really been the top priority of those of us that are working in public service and trying to vaccinate a very vulnerable group. And so that really has been our priority, really raising awareness and education about the importance of the vaccine, creating access for seniors that may have difficulty getting to our large super pods, working with senior centers, community centers to create points of distribution for vaccine on a much smaller scale to address our frail population. And so right now, I think we're just now starting to take a look at how in Orange County we want to approach the Master Plan for Aging. We know that we want to raise awareness, so we're delighted when we're invited to events like this. This is the inaugural, but I know that there are some other events in the pipeline where we will get the opportunity to share about the state's master plan and Orange County's interpretation. We also want to be able to build on and acknowledge what's already working well. Orange County has a strategic plan for aging group and an aging services collaborative that have partnered with this particular event. So in many ways, Orange County is ahead of the game when we take a look at the state's recommendations in the local playbook about gathering our stakeholders. Our stakeholders are already gathered. So we just need to channel that energy and that passion into work that really supports the master plan, because that will really be our guiding North Star for the next 10 years. So we need to ensure that alignment. We want to support efforts that bring resources, particularly new resources for older adults and aging programs into Orange County. So we're going to be keeping our eye on some additional funding opportunities or legislation that creates new funding streams and resources for aging programs. We also need to coordinate with several other county departments. Orange County is a big place, and unlike other models throughout California, our aging services are delivered through multiple county departments. So the Office on Aging lives in the OC Community Resources Agency. We also have our Social Services Agency that oversees adult protective services, in-home support services, the Medicare, Medi-Cal population. And then we also have our healthcare agency that provides direct services to older adults through their public health department, as well as their behavioral health services. So we are a little bit fragmented in Orange County, and the master plan for us has really created an opportunity for those of us that work inside the county to sit at the same table and talk about efficiency and streamlining services so that we, even in our own county departments, are not duplicating efforts. And then we have been invited by the California Department of Aging to participate or take them up on an offer to conduct a workshop for us in Orange County on how we can implement our local playbook. So that is a coming attraction. We definitely want the opportunity to sit down with the state and hear from them directly on what they are expecting from Orange County in terms of implementing our local playbook. What are going to be the deliverables and what are we going to be held accountable to? So that is another coming attraction that we are very much looking forward to. And so I don't think that we'll be putting out any formal reports or announcements until we've had the opportunity to really sit down with the state and hear from them and learn from them what it is that they envision for us at the local level. And then from there, we are talking about doing a needs assessment. The Office on Aging already does a needs assessment of our older adult population every 4 years to align with our state area plan. But now with the master plan for aging, it's really forcing us to scale that up and make sure that we're doing a more comprehensive needs assessment with our county partners. But that's going to involve community engagement. It'll involve surveys, focus groups, and really getting the input from the community and our service providers that work directly with this population, because we've learned from our colleagues that work in mental health as well as serve people with disabilities that we need that consumer input. We're not going to design anything in a vacuum or roll out any implementation plans without the input from the consumers and the clients themselves. That motto of nothing for us without us. We hear that loud and clear, and that really makes a lot of sense for us in the county, that before we roll out anything that we make sure that we get that input from the community. That concludes my presentation. I don't know if we can take direct questions or if there's time for that at the end. Patty, I'll follow your lead.
Thank you so much. Thank you for a great presentation, Erica. We certainly appreciate the vision and the leadership from the Orange County Office on Aging and Orange County Community Services, and we're looking forward to moving this entire project forward and working together to do so. We'll take questions at the end. So people will be able to put their questions into the chat, and we'll address as many of them as we have time for. Thank you very much. Next up, please welcome Dr. Vincent Nguyen, who is the Program Medical Director at Hoag Palliative Care. He is a geriatrician. He is a hospice and palliative care physician. And since 2009, he has chaired the Orange County POLST Coalition, the Orange County Advanced Care Planning Partners. Welcome, Dr. Nguyen.
Thank you very much, Patty. And what an honor it is to be part of this wonderful group of folks, really to excel, or at least to collaborate to improve the care for our seniors in our community. Are you able to see my slides okay?
Yes.
All right. So my presentation will highlight the importance of palliative care and advanced care planning. And the title is Hope is Not a Plan. So as we know, other than what happened this past year, and we're coming to the tail end of COVID-19, modern healthcare has been successful in keeping people alive longer. However, as we know, as people live longer, they are often afflicted with chronic illnesses that result in recurrent hospital admissions and progressive decline over time. Known as the silver tsunami, the aging population in the United States of 40 million in 2010, which is about 10 years ago. Let me see if I can get this out of here. It was about, in 2010, it was 40 million. It is estimated to expand to more than 72 million by 2030. So that's about an 80% increase. And most of these folks will develop at least one chronic illness, such as cancer, heart and respiratory diseases, diabetes, and Alzheimer's disease. So as aging and chronically ill Americans attempt to navigate our healthcare system, they are encountering a complex, often very fragmented and a confusing systems that often leads to what we call as gaps in patient care. And this leads to a domino effect that reduces patients' quality of life, comfort, as well as quality of care. So let's talk about palliative care. I define palliative care as a whole person approach to improve the quality of life for any person living with serious illness by relieving their physical as well as the psychological and spiritual suffering. Not only are we here to improve the quality of life, but we're there to support the family members as well. From the medical perspective of palliative medicine, I see it as a service that helps patients by addressing symptoms like pain or breathlessness, as well as establishing goals of medical care in order to optimize life in the face of serious illness. However, oftentimes palliative care gets mistaken as it is end of life or hospice care. And I remember coming to Hoag, working here as the medical director about 8 years ago. I was going in to see a patient to help with symptom management. I was stopped at the door by a nurse and said, "Dr. Nguyen, why are you here? The patient's not dying." I said, "Exactly. I'm here to help with pain and symptom management for these patients." So palliative care is not linked with any prognosis. As a matter of fact, it is provided alongside with traditional disease-focused care in the hope of helping people live well and live long. So palliative care optimizes life for the person living with serious illness by relieving symptoms and stress with their illness. So I define palliative care as it's about life. It's about helping people to live. But even if the disease can't be cured or fixed, people still need care along the way. And end of life and hospice care, as you can see from this slide, is that it's a component of palliative care, but it is not all of palliative care. So, so palliative care is not limited to end of life and hospice. And so the way I define this is almost like saying, look, an apple is a fruit, but a fruit is not an apple. So palliative care is a fruit. End of life is pick a fruit, and hospice care is part of that as well. And defined by Medicare, which is the primary payer source in the United States, it defines hospices to basically for people with a prognosis of less than 6 months if the illness follows its natural course and curative intent treatments are exhausted or the patients themselves are exhausted. But nevertheless, being hospice care and end-of-life care being clumped under palliative care still focus on life. Our group, the Orange County Advanced Care Partner, was formed in 2009, and we imagined what success would look like here in the OC, and came up with a vision statement that every seriously ill person receives medical treatments that are congruent with their expressed goals, values, and priorities. It sounds simple enough, but being a physician in this field of palliative medicine for the past 26 years, we don't see it this way. I would say about, when we're faced with serious illness, maybe about 25 to 33% at most are people, seriously ill people, are getting their treatments that are congruent with their expressed goals, values, and priorities. And when we talk about advanced care planning, we're talking about planning and making decisions about healthcare the person would want if faced with a medical crisis. And of course, these are medical decisions that are based on their values, preferences, and discussion with their loved ones. these vital conversations we emphasize is to hope to ensure that their loved ones will not be faced with unnecessary burdens that can occur when important medical issues are not addressed. So in life, we prepare for everything that's important to us. We plan for weddings, the birth of a child, and our retirement. We like to think that we will always be healthy, have plenty of time to make medical decisions for ourselves, but things can happen suddenly and things can change. And as we can see from this pandemic, we saw how quickly things changed. People don't want to talk about it. You know, they think that they don't need to talk about it because, number one, their doctor will make the decisions anyways. And then the second piece is, look, I trust that my spouse and my family will know what to do. The reality, though, is that doctors, we will help, that we will turn to your family to give us direction as to your healthcare choices. It is extremely difficult for us to know what to do if you haven't talked about your wishes. And it also puts a real heavy burden on all of us to have to make decisions on your behalf when we aren't sure what you would want. And, you know, when it comes to future serious illness, I mean, even though we don't think about it or we don't want to think that's going to happen to us, but deep under those layers, I think once in a while these things will pop up and we try to shove it away and then push it down into the corner of our mind. But however, I think oftentimes people just don't know where to begin. So why do we want to leave important decisions to chance, even though it may be too hard to difficult to talk about? Well, it's hard to talk about. It's very, very important to your family and to your loved ones. So planning is important, but whether you make plans or not, in most cases, decisions about what care you receive still need to be made. And family members and healthcare professionals cannot reliably predict a person's wishes. And we know that research has shown that more than half of the patients are unable to participate in end-of-life decisions at the time they are being considered. People at that time are often too sick, they're suffering from dementia, or they're unconscious. Our health system is one of the best in the world, if not the best. And we have created support treatment, and we would not want it any other way. Yet when healthcare professionals, again, are uncertain about what the patient would want, our default is to treat, even if the patient wouldn't want that kind of treatment. We can't talk about planning without COVID-19, of course, and this pandemic has clinicians, health systems, and the government working on multiple fronts to keep people from getting sick and care for those who do fall ill by increasing hospital capacity, ramping up testing, and developing therapeutics or a vaccine. For healthcare professionals, when it comes to discussing end of life or advanced care planning, it's not easy for us. And when these decisions aren't made, and during this time of uncertainty, we focused on the fact that, look, let's not panic, but let's prepare. Let's plan for the worst while hoping for the best. Let me share with you a case. This is Maria. The name is changed to protect her identity. She's a 75-year-old non-English speaking female with a history of obesity, diabetes, cardiovascular disease, and end-stage renal disease. She was admitted to the hospital with respiratory distress and later with respiratory failure due to the coronavirus disease 2019. At the time of her admission, she was unable to speak for herself. And given the restriction on the visitation, it took us a lot of effort to find her daughter, who did not know what the patient's medical wishes were. Before before COVID-19, her daughter has always been accompanying her, the patient who's wheelchair bound, to all of her appointments, including visiting her endocrinologist to check on her diabetes, her cardiologist, checking on her heart, and primary doctor for just general health, as well as dialysis appointments 3 times a week. And in the preceding 3 months to that, she was seeing a physical therapist. Unfortunately, advanced care planning was never discussed. And you would be flabbergasted and say, why don't physicians talk about having these conversations with patients? Well, for us as doctors and healthcare professionals, many of us remain extremely uncomfortable discussing advanced care planning and often feel that advanced care planning is someone else's job. And we hope that nothing bad is going to happen to the patient today. We hope, but we know that hope is not a plan. Anyways, I'm getting sidetracked from the story, so I'll get back to this. So the treating medical team had to resort to a midnight call via telephone interpreter to discuss intubation with a family that was ill-prepared to participate in decision-making. So this woman lingered in the ICU for about 6 weeks and died despite aggressive interventions to save her life. And this, in my opinion, should be a never event. With nobody at the bedside to speak on patients' behalf, incapacitated COVID-19 patients risk receiving goals that are discordant as overstretched physicians and clinicians are forced to act quickly. And we see a whole host, this is just one example of a whole host of cases that we've seen here. And at the peak of the pandemic, we had about over 250 patients with COVID in our hospital that we were caring for. Unfortunately, many of them did go home, but there are cases that stand out with us that just stuck with us, and we look back and say, these scenarios could have been prevented. People could have died a much better death and much more comfort. So this leads us to the whole advanced care planning, why this is so important. The first thing we got to do is let's choose a medical decision maker. That person who's going to be making medical decisions for you will speak for you when you cannot speak for yourself. And the person who you choose to speak for you, you need to trust that this person will follow your wishes and do what is best for you based upon your values and your expressed wishes. I have had patients who have been married 2nd and 3rd time, and he was ill at the end of his life, and he keeps on going in and out of the hospital. And I finally sat down with him in an intensive care unit after being there for about 2 weeks, and we were able to extubate him successfully. And I asked him, what matters most to you? And he says, look, I'm tired of going back and forth to the hospital. I know I'm suffering from advanced cancer. I have a whole host of other disease. And I asked him, so who is your decision maker? And he says, well, it's my wife. And he's been married 3 times. That's his 3rd wife. Nothing wrong with that. I'm just saying that it shows that was his wife. And he looks at her and said, look, I'm done. The next time I get sick, I don't want to go back to the hospital. And I looked at the wife and said, so you're now appointed as the decision maker. What are your thoughts? And she shook her head and said, no, I'm going to do what I think is best for him, and he's going to go back to the hospital again. And I looked at the gentleman and I said, look, I know she loves you a great deal, but I think you may need to find another decision maker. You need to talk about this with the rest of your family. So what you want to do is this: you want this medical decision maker to make decisions in difficult moments, especially during a time when there's chaos, chaotic. When you're sick, there'll be different members coming out of the woodwork, kids, family members coming from New York, from out of state, and they have this guilt, and they will say, well, we have to keep fighting. We have to keep fighting for dad. And this is not something that's unusual that we see oftentimes. Share your wishes. So if you could plan it today, what would the last day or week of your life look like? Where do you want to spend your last day if you're ill? Who do you want to make medical decisions for you if you cannot? What are your ideas and hopes about the end of your life? My ideas and hopes for some people is like, I just want to be home. I just want to be able to make peace with my loved ones. I would want to be able to hold their hands and tell them how much I love them, how much I appreciate them. What are your fears and concerns about the process of dying? You fear of need to make peace with your God. You need to make peace with those around you. You have concerns financially. And the kind of care you might want during the severe illness of when you're dying. Do you want to be in the hospital, in the intensive care units, with us trying to fight and keep you alive as much as we can? Or does it come to a time in your life when you say, look, there's a time to fight and there's a fight for time, and I want to fight for the time to be with my family, to live as well as I can? Do you believe that life should always be preserved by medical interventions as long as possible? For some people, they do. For other people, they say that, look, medical interventions are great, but there comes a time when these medical interventions that are meant to help prolong my life, maybe it's not prolonging my life, it's actually prolonging my dying process. And what does that mean to me? And how do I discuss this with my doctors and my treating physicians and with my family so they understand my values? What kind of mental or physical conditions would make you think that lifelong treatment should no longer be used? We're very good at keeping people or keeping people's organs alive. We have machines, we have, to keep persons breathing, we have vasopressors, we have dialysis, we have blood transfusions, we have many, many things. But at what point is it enough? When a person is unaware of their surroundings, unable to appreciate or continue important relationships, unable to think well enough to make everyday decisions, living in severe pain or discomfort. These are the things we talk about. And the goal of medicine is to help relieve those discomfort. That's what palliative care is about. And we want to help people live well and also die well when it's at that end stage of their life. The other piece that's important besides expressing your wishes and picking a decision maker is about documenting your wishes. You don't put it in writing, it's going to be a lot of hearsay. So consider an advance directive. An advance directive is just a form that allows you to name your decision maker and for you to write down what you want for your medical care. We recommend that everyone above the age of 18 should have one done. And if you have an advanced directive, review it, update it, and share it. We have families and friends, they share this around the holidays. Not that they want to break the sadness of the holiday, but it's more like, I got all my kids here, I got my family here. I just want to sit and talk before we have cake, before we have tea. I just want to let you know these are the things that's really important to me. I'm grateful for my life. I'm grateful for my family. I'm grateful for the time that we have here together, but I also want to let you know that I have this advanced directive, and this is really important to me, and I want you to be comfortable with that. When that's done, put it away. Okay, so you want to be able to, we know that the advanced directive is put away and locked in behind drawers and so forth, but you want to share this with your doctors, your treating doctors, and even the hospital. Here at Hoag, we use an EPIC, which is a program in which we're able to, this is basically your electronic medical records, and we're able to put your advanced directive in the computer system. So anytime you go in and out of our hospital, it's there for us to have. So that, of course, we'll always ask you and check the form, because people change their mind sometimes when things are getting worse, and what they planned 10, 15 years ago may not be true today. And what about the POLST? We're a big POLST proponent, and in 2009 we had the blessing, I would say, of receiving a 2-year grant, in which I asked Patty to be my co-chair, to take on the POLST and expanding the POLST form in Orange County. And that started our vision, that started our dream about how do we improve care for people. And as a palliative care doctor, when I looked at this form back in 2009, I just saw how simple it is and how elegant it is. and it's so easy transformable. It can go between places, it stands out. But we also see that as easy as it is, it can also be easily misunderstood. And so we've been out there in the community educating and re-educating, helping people understand that it's not a death wish, it's about putting your wishes down when someone is seriously ill. So POLST is not it's not someone that every time you go in a nursing home, you ought to have one. You know, some people are there for rehab, so they're there for a short period of time, they go home. But for people who are seriously ill, or those I would say who calls the facility, the nursing home, their home, they ought to have at least a conversation, at least have an advanced directive. And for those who are quite advanced in their illness, they should have a POLST. And we talk about the bright pink form, and the beauty and the elegance of the POLST expresses the exact wishes about certain medical treatments. And it's a signed medical order that the medical team can act on. I don't want to spend this time talking too much about the POLST or go into detail, but I just want to give you the highlight of our recommendations. So this is my last slide, and as you saw my first slide, I entitled it, Hope is Not a Plan. Hope is a feeling of aspiration, it's a desire, but it's not a plan. Hope helps us cope and live in the amidst the unknown, but still it's not a plan. So when the plan is unclear, the default is to treat aggressively. And not only is the patient getting treatments that may not be consistent with their wishes, they may be suffering from the treatments that we're providing for these people in the hope of keeping them living longer. But however, it leaves the family with uncertainty and stress, guilt and depression and financial concerns. And over the past years, when Patty and we go out in the community, we give talks to the community, almost every single presentations we made, when we have at least 20 people or more, there's usually at least 1 or 2 people that would come up and say, you know, I still feel guilty about what I did for my mom, my spouse. Did I do something wrong? How come I didn't know about this? So these guilt just kind of linger with people, and we just listen and we assure people, look, you did what you did because that's all the information you knew. But now that you know better, make sure let's not make the same mistake again to prevent that from happening. So we continue to hope for the best while we prepare for the worst case scenario. And once we have our plans in place, we can go on back on living each day to its fullest. So thank you very much for this opportunity. And again, I look forward to the Q&A session and going forward with the collaboration and here in the OC to really advance medical excellence in our community. Thank you very much.
Thank you so much, Dr. Nguyen. And I know people are going to have a lot of questions and comments. There's already some coming into the chat just now. We certainly appreciate that perspective on how important advanced healthcare directives are and planning ahead is in the continuum of care. And for one, I'm just really glad that the Master Plan for Aging calls out the need to increase awareness about advanced care planning and appropriate use of the POLST form. Thank you so much. Stay tuned for questions. Coming up next, I'm very pleased to welcome Jackie Mark. Jackie is a Senior Policy Advisor in Government Affairs for CalOptima. She's going to share with us CalOptima's response with their programs and services for aging adults. And we really look forward to how CalOptima, which ensures 25% of the population of Orange County, how CalOptima is going to respond to these directives in the Master Plan for Aging. Welcome, Jackie.
Thank you, Patty. Can you hear me okay?
Yes.
Wonderful. Good afternoon, everybody, or good morning, it's still morning. I'm happy to join you today on behalf of CalOptima. As Patty mentioned, my name is Jackie, and I work in the Government Affairs Department. And the Master Plan for Aging is definitely an exciting movement in senior care in the state legislature. We're very excited to be collaborating with the County of Orange as we begin to monitor the state's master plan for aging as it moves through the budgetary and legislative process. While we await state direction on what CalOptima can respond to and do in regards to the master plan for aging, I wanted to share with you today some of the existing covered Medi-Cal programs that some folks may not be aware of already exist, and with the passing of the master plan on aging would only further enhance access to these services. Next slide, please. For those who may not be familiar with CalOptima, just would like to provide a high-level overview. CalOptima is Orange County's Medi-Cal plan. We are the sole Medi-Cal plan serving approximately 820,000 Medi-Cal members here in Orange County. We have 4 lines of business: our Medi-Cal program, our One Care Connect program, our One Care program, and then our PACE Center, serving older, frail adults aged 55 and older who require skilled nursing level of care. Next slide, please. Wanted to provide an overview of long-term services and supports through the Medi-Cal benefit lens, and to share with you how Medi-Cal members become aware of long-term services and supports. Each new Medi-Cal member must go through, or is invited to go through, a new member orientation. And during that new member orientation, they go through the member handbook, as well as learn all of the covered Medi-Cal benefits, including those that I'm going to chat with you about today. An example of long-term services and supports includes skilled nursing care, social services, personal care, nutrition services, and even transportation services. And CalOptima's long-term services and supports include programs such as CBAS, which is the Community-Based Adult Services, the Multi-Purpose Senior Services Program, and long-term care. Again, all of these items are listed out in the Master Plan for Aging and would further enhance these types of services for CalOptima's older adult population. Next slide, please. CalOptima's LTSS coordination requires case management throughout our LTSS department. We currently review referrals, we have medical authorization to provide assistance in those intakes and referrals, and then it goes through our nursing staff for the final approval, just to ensure that eligibility criteria is met. And you can see here on the slide that they really focus on providing care management activities for members receiving these kinds of services. Next slide, please. And although folks are very familiar with CBAS, especially those at Alzheimer's Orange County, CBAS is an outpatient facility program that offers health and social services to frail older adults and folks with disabilities. There are currently 20 CBAS centers throughout Orange County with services available in multiple language. However, due to the COVID-19 pandemic, the CBAS centers are currently operating under a temporary alternative services plan, which has allowed these CBAS centers to provide telehealth services, home visits, and meal delivery care. Next slide, please. It's very important that folks are aware how somebody who receives Medi-Cal can be eligible for CBAS. And listed here in front of you, you'll see they have to be a Medi-Cal member and assigned to CalOptima. They're 18 years of age or older, diagnosed with chronic physical, behavioral, or memory problems, required assistance and supervision with activities of daily living, and are at risk for placement in nursing home. And so as a Medi-Cal covered benefit for CalOptima's members, our case management department really looks at some of the current medical conditions one of our members may have and refer them to a CBAS center, especially if it means preventing somebody from going into a nursing home if they don't necessarily need that high level of care or care that can be provided at a CBAS center. Next slide, please. CBAS referrals, as I mentioned, do occur in-house, but for more information about CalOptima CBEST Center, or to even make a referral if you have a client or a family member in mind who may benefit from participating at an adult day center, please use the phone number listed on your screen. Once CalOptima receives the referral, we do complete a pre-screen eligibility review, and then a social worker will contact that member. Next slide, please. The Multi-Purpose Senior Services Program, or MSSP, is definitely becoming a growing need for older adults. Both the Master Plan for Aging and the state's CalAIM initiative discuss the Multi-Purpose Senior Services Program. It's truly an intensive home-based care management services program provided to assist clients to ensure that they can remain comfortable in their homes and in a safe manner. Of note, the state plans on carving out this benefit from managed care plans and be managed by the state. This will be completely transparent to CalOptima's members and will not affect them in any way. It's mostly on the back end and the payment side of things. But it's truly a beneficial program for folks with high needs who wish to remain in their homes. The MSSP program also provides additional services that may be provided under the program, such as a supplemental homemaker choice or personal care services, nutritional supplements, handyman services, in-home respite, and other items to allow them to remain safely at home, such as security bars or even having a new refrigerator. Next slide, please. Those eligible for the MSSP program, it definitely goes through an extensive review process, and they must meet all of these requirements you see on your slide. They must be 65 or older, receiving Medi-Cal, as it is a Medi-Cal covered benefit, reside in Orange County, as well as the other things you see here on the slide. Next slide, please. For more information on how CalOptima MSSP referrals can be processed, please feel free to call any of the phone numbers on your screen or send us an email. And a referral, once the referral is received by our MSSP department, they go through the preliminary eligibility requirements that you saw on the previous slide, just to ensure they meet those minimum requirements that are set in stone by the state. The social worker then conducts an in-home psychosocial and functional assessment and make sure that the MSSP program is the best program for them. One of those is ensuring that they can reside safely and independently at home, or if a referral to the PACE Center or CBAS, and if necessary, a skilled nursing facility may be a better choice of care. Next slide, please. The long-term care program provides skilled nursing and rehab services in a nursing facility to improve the member's clinical and functional status. And CalOptima's long-term care benefit is authorized by our LTSS department. We pay for the medical care as well as room and board in a nursing facility. The use of benefit is based on the state's Medi-Cal level of care criteria, and we focus on transitioning a member to the least restrictive living environment in the community. Next slide, please. Members and families or authorized representatives should explore options for long-term care referrals. They can contact a facility in the member's area. We have a list of those available on CalOptima's website. We encourage folks to set up a tour of the facility and then work with the nursing facility social worker and the primary care physician to ensure that is the proper placement choice. All members admitted to a nursing facility must have their doctor's orders available, and CalOptima then initiates the authorization and admission process. Next slide, please. And next, we'd like to share more about hospice, and I know this has been discussed before. Hospice focuses on the care, comfort, and quality of life for a person with a serious illness who is approaching the end of life. This may be a serious illness such as a disease or condition with a high risk of death that affects a person's quality of life or ability to perform daily tasks. Examples of serious illnesses that CalOptima's members may benefit from using hospice are including those who have dementia, cancer, heart failure, and chronic obstructive lung disease, to name a few. Authorization for inpatient hospice services, such as a skilled nursing facility or hospital setting, are provided by CalOptima. The authorization goes through 4 levels. We've got routine hospice that could be provided in the member's home. We have respite, where the caregiver gets to essentially take a break, and the patient goes to a skilled nursing facility for a few days. There's continuous care level of hospice, where a private duty nurse is provided for patient care in the home and at the bedside. And this is mostly brought in to help with pain management or unusual symptoms such as bleeding, upset stomach, and other unusual symptoms. And then there's general inpatient, which is provided by the skilled nursing facility, in a skilled nursing facility or hospital setting, and again, to really focus on that comfort care and managing somebody's symptoms. Next slide, please. Members can discuss hospice services with their provider, and hospice services are requested by a provider and then provided by the hospice agencies. So just to clarify, CalOptima does not provide hospice services. We essentially provide the authorization for those services. Next slide. And lastly, palliative care, and I know Dr. Nguyen spoke a lot on this, so I won't go into too much detail. But the Medi-Cal benefit for CalOptima members are for those who have advanced illness and are experiencing a continued decline in health status. They're more than likely to have started the use of a hospital or emergency department to manage this advanced disease. They are not yet enrolled into hospice, and they agree to participate in advanced care planning discussions that our case management team can walk the member through. Next slide, please. Palliative care referrals, as similar to hospice care, the members discuss palliative care services with their provider. An authorization provided by CalOptima may be required for palliative care, and palliative care services requested by a provider may be provided in the provider's office, hospital, nursing facility, or in the comfort of a patient's home. Next slide, please. And lastly, we'd just like to share with you a long-term services and support success story of a 69-year-old CalOptima member who was diagnosed with Parkinson's disease and dementia. And you'll see here, lived at home with her husband, who was the primary caregiver. The spouse had become overwhelmed with the care of the member, so the family was looking at nursing homes. The member was then referred to CBAS centers, and member was receiving over 53 hours per month of in-home supportive services. CBAS nurse then referred the member to other CBAS centers. Additional IHSS hours were provided, and then the MSSP program department came in for an evaluation of those services. And then in the results of LTSS coordinated care, IHSS hours increased to 269 hours per month, which you can definitely tell the member needed a lot of hands-on care and support. The member was then enrolled in a CBAS center that could provide the higher level of care that was required. The family benefit was increased in support for both the member and the spouse. Because the member could receive additional hours through IHSS, the load of the spouse decreased. And then the member's spouse and the family were no longer overwhelmed, and the member remained in her home with her spouse. And it's programs such as LTSS that are outlined in the Master Plan for Aging, the CalAIM initiatives, and current Medi-Cal covered benefits that really become a benefit and support system to CalOptima's older adult population. And that concludes my presentation.
Thank you so much, Jackie. I think it really helps us all to have a review of what CalOptima does provide for so many people here in Orange County, and some of the innovative programs that, that really respond to the needs of aging older adults. I want to thank all three of our presenters for today, and if you'd all come back on the webcam and activate your microphones, we will look at questions. For those of you who asked about receiving forms, if you will check the chat, my email will be there, and if you'd like advanced directive forms or copies of the POLST form, just email me and I'll be happy to get those sent out to you. Provide a US mail address so I can send hard copies, and let me know how many you need. One question here is, to ensure our older adults are protected from abuse and bad care, there's going to be a much greater need for more caregivers regardless of what housing or environment our older adults are in. Age in place will be a more desired goal for many older adults. Caregivers who are well trained in compassionate, person-centered care will be needed. Are there any plans included in the Master Plan for Aging initiative on how to attract more qualified caregivers and give them adequate training? So Erica, do you want to field that question?
Sure, and that's exactly right. It is definitely a need that both the state and Orange County are aware of. It is called out specifically in the Master Plan for Aging under one of the main bold goals is caregiving that works. So those are some of the strategies and initiatives that fall underneath that goal. In terms of caregiver training, the Office on Aging has a family caregiver support program. We contract that service with St. Jude Hospital. That's our partner for the Orange Family Caregiver Resource Center. So we'll be working closely with them and the state to talk about what their vision is for caregiver support and training. Also, our in-home support services program will be deeply impacted by that initiative because they oversee the public authority, which provides caregivers that are for clients that are on the in-home support services program. So it'll be twofold, but there is nothing concrete planned right now. We're still in the preliminary stages, but thank you for the question because it definitely keeps that issue in the forefront.
Thank you, Erica. Dr. Nguyen, here's a question for you. How should someone access a POLST form, and does it have to be notarized?
Well, you can access the POLST from the internet. You can go to the California POLST, P-O-L-S-T, or you can reach Patty Mouton. And I'm sure I just volunteer Patty, but we've been going out there, and at our conferences, we usually hand out the POLST to people. And as for the POLST, the form, like I said, is very simple, but it's also very elegant, is that it does not need to be notarized. It needs 2 signatures. The first signature it belongs to the patient who had that discussion with the physician to go through what the criteria, what's important to them, such as, you know, in the event should my heart stop, I stop breathing. In another word, I'm dead. Do I want to be resuscitated and try to see if the doctor can pull me through from get my heart beating again? Or when that happens because I have a serious illness and I have a terminal condition, just allow nature to take its natural course. So those are the things in which you discuss with your doctor. So you sign that. You can't speak for yourself. Your durable power of attorney of healthcare can make that for you, and sign along the line. And the second signature is from the physician or the nurse practitioner or the physician assistants who've had that conversation with you. So it does not need to be notarized.
Great. Thank you, Dr. Nguyen. A follow-up question is palliative care supported by Medicare? And do we have providers of palliative care here in Orange County?
Great question. I'm going to start with the palliative care provider. You know, there's not enough palliative care provider out there. You know, since it's number one, it's a new medical specialty. When you talk about, I'm going to go and see my cardiologist, and I go, okay, cardiac, heart, pulmonologist, lung. How do you say a palliative care doctor? Is he a palliologist? And it's relatively new field, so we're always out there trying to explain ourselves and help people understand and knowing that we're there to support them. With that said, though, you know, we're constantly training new doctors. And I know that every single health system, every single hospital, well, here in Orange County, the main ones, UC Irvine, the Missions, the St. Joe, the Providence Health, and the Saddlebacks and Memorial Health, like I said, they do have palliative care services. And currently, palliative care is pretty big in the inpatient setting because it's where the patients are. But there's been a huge movement to bring palliative care outside of the hospital. And currently, it's being served traditionally it's been served under, it's been carved out of home health. But there are some freestanding palliative care programs that's willing to take the hit, you might say. Hit here is in terms of financial reimbursement, because with palliative care reimbursement is pretty low. So for any health system to have this, it's not a money generating service. It's more like, I want to do this because it's the right thing to do to the community, and we do the right thing, we can save costs that way. So I guess I'm because this is relatively a new field, we're seeing palliative care within medical groups, physicians who are there practicing and they're able to bill for their services. And like I said, being a palliative care doctor there's not a whole lot of us because it takes an additional training, and the time that we spent with patients and family are long. There's not enough of us, but just know that we're constantly striving and collaborating with healthcare systems, payers, to see how we can make this work. And palliative care is not just, well, you have a doctor, but there's social worker, there's palliative care nurses and chaplains. So it's when you talk about palliative care, it's not always being a doctor, it's just the straight psychosocial. So you go and see a social worker, and spiritually see a chaplain who specializes in palliative care. So I hope that helps. I mean, thank you for that great question. This is something that we're working toward.
Great, thank you, Dr. Nguyen. Erica, the question is, would you discuss more about what items from the Master Plan for Aging will be worked on first? They'd like some specific examples of what initiatives we're going to work on right away.
Well, like I mentioned, we don't really have a prioritization plan just yet because we want to be able to sit down with the state and hear from them what they envision the priorities are. But we do want to be able to explain what Orange County is already doing well, that we think are in some ways ahead of the game. And that is, taking a look at our local data, because we need to understand what our data looks like to be able to tell the story. And we also feel like the local playbook that calls out getting your stakeholders together, that in many ways we're already ahead of the game, with that regard. We also want to be able to kind of map what Orange County is already doing that the master plan calls out, because we don't want to duplicate efforts. If we can refine or refocus, that will take a lot less energy and effort than trying to develop something new that doesn't exist. And so that, I think, will be some of the low-hanging fruit that we can tackle first.
Great, thank you very much. Jackie, this is a question for you. Is Medi-Cal eligibility largely based on patients' income and assets?
Hi, Patty. Thank you for that question. That is correct. So it's called the federal poverty level, which is set by our federal government. And if you visit Covered California's website, they have a really great chart that kind of shows the sliding scale. In order for somebody to become eligible for Medi-Cal, they must make 138% or less than the federal poverty level, which for a family of four is about $30,000. So it's not a large income. And then as somebody's income goes up, or if it's a family of 2 or 4, 5, Covered California demonstrates that financial threshold, or where Covered California and state and or federal subsidies may be available to help ensure folks do have access to healthcare.
Great, thank you very much. So it's an income and asset-based threshold, and it is for people of limited means. Here's a question. Dr. Nguyen, how old do you suggest someone needs to be in order to complete a POLST document?
Yeah, the POLST is not meant to be ageist in any way. It's meant really for people who have a serious condition. And when you talk to your doctor, you know, people living with congestive heart failure, with diabetes, with COPD, with early dementia, I mean, these are the kind of things that you should have at least an advanced directive done. However, when it comes to the POLST, there's no specific age, but I guess the older we are, the closer we are to that end game. I think we should have one done. So, you know, it can be if someone who's young in their 40s and they have glioblastoma multiforme, which is a very deadly brain disease, they should have a POLST completed. But if someone who's healthy, they're 85 years old, still going out there and playing tennis and relatively healthy, I don't think it's needed, but they need an advanced directive. So it's really meant, it's more illness focused than anything else. But even before the POLST is completed, it's always good to speak to your family. And we know that, you know, anything can happen spontaneously. That's really not meant for people who are relatively healthy.
What about that surprise question, Dr. Nguyen?
The surprise question. The surprise question is really for the doctors. And we want to ask the doctor, say, hey, would you be surprised if this person would die in the next year based upon their illness and their recurrent hospitalization? If the doctor in his mind said, yeah, I do believe the patient has a high chance of dying the next year, that would be a time for the POLST. And so that's a conversation between you and your doctor. And it's good for family members when they have a loved one who can't speak for themselves, people with dementia who's bedbound and not able to speak for themselves. And we know that with the trajectory of dementia is that the person will lose their ability to swallow, and they most likely will end up in the hospital with aspiration pneumonia. So these are the kind of things in which you will have to have a conversation with the doctor and make sure that you tell the doctor that you are a straight shooter. Tell me I want you to tell me, doc, what's going on with me, and try not to hide it. And we're open to have these kind of conversation. Because the doctors also, even though we kind of shy away from it, a lot of us are waiting for the family to give us that hint. But at the same time, sometimes the family will say, well, I'm waiting for the doctor to give me the hint. So we kind of speak across each other. So just having that open line of communication extremely important.
Great, thank you. Here's a complicated question. How does nursing home placement process work? How does placement start, and who pays for it? So who would like to take that to start with? That's a tough one. Jackie, do you want to talk about how CalOptima might start the process for placement in a skilled nursing facility?
Sure, and I know it was on the slide provided as so let me pull that up real quick. So it'll start with discussion with the doctor and provider, making sure that that level of care is what's necessary. And as they go through that assessment, proper placement is what's really going to be the priority. Is a skilled nursing level of care the best option for that member? Or can they benefit from a program at home, such as the MSSP program, participating in PACE or a CBAS center, so long as they have the necessary care and support in the member's home. And if they are a Medi-Cal member, CalOptima and Medi-Cal does cover that benefit. And if it's somebody who's what we call dually eligible, where they have both Medicare and Medi-Cal, Medicare is the primary insurer, and once those benefits run out on the Medicare side, then Medi-Cal steps in to pick up the rest of those services.
Right, I could jump in. Yeah, I could jump in about that too, because from the hospital setting, when someone who's admitted to us and we're planning to discharge, we work with the team and with our discharge planning and case manager, we feel that the patient's not steady enough to go home. Oftentimes the patient will go to a skilled nursing facility for a week or two, sometimes 3, for rehab, just for stabilization or continue with their treatments before they go home. But during that transition in the skilled nursing facility with further assessment, it's recognized that this person will not be a safe discharge, and this is when more conversation will be had. So it's all really about communication, conversation with family, and just being transparent with the treating team with the family. And I can tell you, not everyone is excited. Say, gee, I can't wait to go and live in a nursing home for the rest of my life. But it is a reality which we know that people fear this, and that's just why it's so important that the nursing home are adequately staffed, trained, and make sure they get enough adequate resources to care for these frail people who are afraid of being taken out of their own comfort in their own home.
Indeed, indeed. We have another complicated question as we wrap up, and that's how can I schedule a comprehensive evaluation of what my mother would qualify for? I've been caring for her. She has dementia for 9 years. I'm overwhelmed and have tried several times over the years to determine the best way to get care for her. I tell you what, in our chat is our helpline number for Alzheimer's Orange County. That number is 844-373-4400, and you can speak with one of our social workers and get that process underway, and they'll help you connect to the community resources that might help you put together a plan of care that would provide you with some respite and get your mother all the care that she needs. It's 10:30. We're out of time now. This has been a really, really great way to introduce the Master Plan for Aging in California to our Orange County community. And I so appreciate the collaboration and the cooperation and the participation of our 3 excellent local speakers, Dr. Vincent Nguyen, Erica Danczak, and Jackie Mark. Thank you very much for this informative program today. And we certainly appreciate all of you that have attended. And if there are questions that are not answered, then we'll do our best to follow up with our audience today. This program is recorded, and so you will be able to watch it again from our library. And we encourage you to download the handouts that are available on your control panel. Thank you very much. On behalf of all of the collaborators, we hope you have a great day, and we really appreciate your participation with us. Thank you.
Thanks, Patty. Thanks, Erica. Thanks, Jackie.
Thank you.